Greetings, everyone. My name is Araceli Cabalon, and I am a nurse practitioner currently connected or working with the Department of Veterans Affairs in Santa Maria, California. And obviously, all of my patients are veterans from all services, the Army, the Air Force, Marine Corps, Navy, and even the National Guard. Before joining the VA, I am a public health nurse, and I am engaged in being with the youth and the adults in the sex industry in the county of Los Angeles. Okay, in this video, I will be presenting the stakeholder education plan for my clinical scholarly project titled Their Beacon in Turbulent Times, The Effects of Faith on Mental Health of Migrant Families in Santa Maria, California. To provide a little more context regarding my clinical scholarly project, I will be dictating its speaker, which is the following. P stands for migrants who are current members of a chosen church in Santa Maria. I are the religious faith and the consistent church activities. C are the migrants who were former members based on the church database that they stopped coming to church. And O is the improved mental and physical well-being during the COVID-19 pandemic. And T is obviously it's the time in a span of 3 months. Migrants, in other words, are those current members of a chosen church in Santa Maria. Can religious faith and consistent church activities improve their mental and physical well-being during the COVID-19 pandemic compared to those migrants who are former members who stopped coming to church based on the church database in a span of 3 months? Stakeholders, according to Spiritus Burden et al., 2021, noted that migrants are often at risk of having poor mental as they are exposed to several negative factors, including visible and or unsafe living conditions, economic uncertainty, and alienation. Threats to a migrant's mental health are even more pronounced during the COVID-19 pandemic, when millions in the United States alone have to contend with the abrupt changes in their lives. A migrant who has little to or no support at all in his or her new environment will likely face increased difficulties in various aspects of living, thus leading to the rapid deterioration of his or her mental health. Although it is undeniable that COVID-19 pandemic has affected and continues to affect many groups, migrants are among the most vulnerable. And so therefore, clinical studies should focus on how to provide opportunities for migrants to nurture their well-being, even while still in the period of adjustment. Older migrants, in particular, are doubly susceptible to poor mental health. Considering the reduced resilience, some of them may even struggle in identifying resources that are relevant to mental health, or completely reject the need to seek professional help due to an upbringing that stigmatizes mental illness. The aim of this stakeholder education plan is to shed light on how non-clinical settings such as churches can be instrumental in the creation of a support and the dissemination of mental health resources, as well as the destigmatization of mental illness. In healthcare, stakeholders pertain to groups that have vested interests in matters concerning healthcare, according to Cottrell et al. 2014, particularly the development and the implementation of healthcare policies and the provision of quality services. These are the number of stakeholders in healthcare, but they can be reduced to four, namely the policymakers, patients, providers, and the payers. They are sometimes also collectively called as the four Ps, for they are the most active shapers of healthcare. Policymakers are responsible for, to begin with, the policymakers are responsible for the collection of data from other stakeholders, which then they utilize in the creation of metrics for the economic aspects of healthcare policies. Meanwhile, the patients are those who employ the services of providers, and majority are also the customers of payers. Seeing as patients are citizens who vote and pay taxes is the duty of the policymakers to reciprocate this nation-building acts by championing healthcare policies that are beneficial to all and not just to a specific class. As for the providers, they operate in accordance with the existing healthcare policies. Providers have the responsibility to maintain and to protect patients' records and also to coordinate the treatment of their patients with one another. Lastly are the payers, who avail healthcare services for their beneficiaries like patients, while also ensuring the financial feasibility of their healthcare plans. For any clinical scholarly project, securing stakeholder support is vital. Without this, the project would likely not reach the implementation stage. Stakeholders play many roles in healthcare projects, with the most important being providers of insights on the necessary accommodation that must be made so that the healthcare provider would garner a positive reception from the public. Stakeholder engagement is the process of strengthening relationships with stakeholders by maintaining open communication and allowing them to be involved with the various stages of a clinical scholarly project, such as data collection and analysis. In this clinical scholarly project, the most important stakeholders are the patients, followed by the providers. The policymakers, to that extent, are relevant to this as well. To begin, the patients are migrants. Role is to help provide data on how faith, including church, belongingness, contributed to the improvement of their mental health, especially during the trying times of such as COVID-19 pandemic. This is to be done mainly through answering questionnaires and undergoing interviews on their experiences revolving around mental illness and mental health care. As for the providers, should a clinical scholarly project attain significant success, they are to collaborate with communities and policymakers in creating opportunities that would allow non-clinical settings such as churches to further aid in dissemination of mental health care resources and the destigmatization of mental illness. Among the recommendation of the National Academies of Sciences, Engineering, and Medicine is the inclusion of the grassroots and peer support in the campaign for better mental health care. One way of doing this is by collaborating with church leaders in promoting mental illness, mental healthcare education, and peer support among the members. This clinical scholarly project shall utilize evidence Donne-Bidian's model of care in conjunction with Madeline Leininger's transcultural nursing theory. Donne-Bidian's model is comprised of three parts, mainly structure, process, outcome, or it's just about the academy. Structure pertains to the attributes of the provider and the setting where healthcare or clinical scholarly project will occur. In this case, it's the provider as a nurse practitioner whose aim is to determine how faith helps in improvement of migrant mental health during the COVID-19 pandemic. NP will conduct the clinical scholarly project in specific church in Santa Maria, California, where majority of the members are migrants. Meanwhile, process pertains to on how the systems or processes of a clinical scholarly project will operate in order to achieve the desired outcome. In this case, the NP will disseminate questionnaires, conduct interviews, assessing the mental health experiences of the migrant participants. Furthermore, the NP will provide seminars in partnership with a pastor or speaker or we will get a speaker who is a mental health advocate that will expand the migrant participants' understanding of mental health and mental illness, as well as promote mental health care. And lastly, it's the outcome, pertains to the conclusion of the clinical scholarly project. And whether or not to know who was able to elicit positive results. In this case, the desired results are, number one, it is the improvement of mental health through faith and belongingness. As a church community, one can become a support system. And two, the destigmatization of mental illness and the promotion of mental health care through health sector and community. And in this case, is a church partnership. Donne-Bidian's model of care was chosen because it is because of its universality, but also because Donne-Bidian himself later on emphasized the importance of maintaining genuine connection with one's patients. Donne-Bidian was worried about the industrialization of quality improvement. And so he mentioned in an early interview that the secret quality is love. You have to love your patient. You have to love your profession. You have to love your God. This belief of Donne-Bidian can be appropriately connected with Leininger's transactional nursing theory, which gives importance to culturally relevant and competent care in diverse communities. This is indeed important, considering that migrants come from different sociocultural and economic backgrounds. And even the NP herself must learn to understand how varying beliefs in mental illness and mental health care are shaped. To be culturally competent is to help patients process the challenging stages of life in culturally meaningful ways. Through cultural competence, patients are empowered to take an active role in their own health care. Since the clinical scholarly project is patient-centered, the educational need will focus on destigmatization of mental illness and the promotion of mental health care for the migrant participants. Stigma continues to be a significant barrier when it comes to seeking professional help for one's mental health. Oftentimes, it is often responsible for introducing moral injury and or exacerbating one's condition. By helping the migrant participants understand the importance of nurturing their mental well-being, they would be able to slowly unlearn harmful misconceptions regarding mental illness and mental health care. And in turn, they will become proactive in monitoring and caring for their own mental health. Stigma is further divided into three levels. And they are one, it's self-stigma, which is the stigmatization of oneself, affiliated stigma, which is the stigmatization of someone close, and cultural stigma, which is the stigmatization of perpetuated by customs and laws. This stigmatization, mental health in general, does not happen overnight, especially when it comes to migrants who hail from different backgrounds that disregard or even vilify mental illness. Partnering with non-clinical yet influential communities such as churches, however, can be the first step in expanding the campaign of destigmatization. To give an overview of the clinical scholarly project, the NPO and with her assistant will conduct and interpret interviews and other vital data to be retrieved during the project. Questionnaire assessing current mental health and mental health perspective shall be given each migrant who is required to answer it before proceeding with the other parts of the project. Then, toward the end of the project, an educational bookmark will be given to each participant. This reminders about valuing mental health, as well as reminders about mental health care and faith can work together. Pastor or speaker is also an advocate of mental health care will deliver a seminar in the destigmatization of mental illness and the promotion of mental health care during the beginning, the middle, and at the end of the project. Finally, at the end of the project, the migrant participants will share their experiences about the project and the mental health care in general, and also provide recommendations on how future seminar studies can be improved. This concludes my stakeholders education plan on my clinical scholarly project regarding faith and mental health during the COVID-19 pandemic. Hopefully, you can also join in this endeavor to expand mental health care opportunities through non-clinical settings.